we spend so much of our lives working on this kind of stuff. It doesn't make any sense to do stuff that's just like so-so. You really, really want to do something that makes a difference. And I committed myself. I've looked at aesthetics many, many times, many other areas, and I'd never done anything in aesthetics before because I always felt like the results, like if I can't tell the results are better, I can't get into it. For this, this was a difference maker for me. And our goal was to do something that when you look at it, there's no doubt, even the biggest skeptic, if you see it, you see a big difference. And that's what we were going for.
Hello, and welcome back to the Technology of Beauty, where I have the opportunity to interview the movers and shakers of the beauty business. And today is no exception. Today is a very special day. Today we get to interview Josh Makower, who flew down from San Francisco just to be with us on this show. Hi, Josh.
Hey.
Thank you so much for joining us.
Thanks for inviting me.
I've been bugging you to do this interview for over a year.
You have.
And finally,
I'm happy to be here.
You're gracing us with your presence. I cannot tell you how happy I am.
Yeah, no, I'm happy too. We were waiting for some important, exciting news, and we're ready to share that now.
Great.
So I'm ready to be here.
That's right. That's right. Now, you have a very interesting background.
Thanks.
And there's a lot of listeners and viewers right now who don't have a clue. If nothing else, that you're a doctor. You went to med school.
I did.
And there's a lot more to it. So let me start with this.
Yeah.
Where did you grow up? Where did you go to high school? Let's start with that.
I went to Ramapo Senior High School in Rockland County, New York.
Okay. So you grew up in New York.
I did.
Where'd you go to college?
I started my college at Case Western Reserve University, and then transferred to MIT. I finished my degree, my bachelor's degree in mechanical engineering there, MIT.
So you got a mechanical engineering degree.
Yes.
And then you decided to go to med school.
I did. I wanted to use that engineering degree to create things for improving medicine, and so I thought that I should go to medical school and learn about how medicine is taught to doctors. So that's why I went to medical school.
So when you went to med school, did you know you would not be a clinician?
Not exactly. I went to medical school thinking I would be a physician that would be involved in creating things like you. I mean,
You'd be me when you grew up?
Yeah, I wasn't able to be you, so the next best thing. But no, I wanted to, so I did go thinking I'd practice medicine and then also create, new technologies and that kind of thing. And there weren't a lot of role models that did that at that time.
Well, that's why I'm asking about it. And there's a lot of people watching this,
the
Akashas of the world.
Right.
And young folks that have trained with you and spent a little time with me, who now have some mentors like you to follow in. But I know you blazed a trail that had never been done. So that's what I want to pull out of you. So off you go to med school, 4 years.
Right.
And
you
graduated, I hope.
I did graduate. I do have my degree. But I decided at that point I wouldn't match, and I would, at that point, transition my career to use my MD to create new technologies and try to improve health that way.
Okay, so I didn't pull out of you. Where'd you go to med school?
Oh, NYU.
Yeah.
Yeah, in the city.
Okay, so match is when a person decides to do an internship, for those of you non-physicians. So you decided on your 4th year of med school or something, okay, I've got the medical degree.
Yeah.
I've got my engineering degree.
Exactly.
And where did you go after med school?
After medical school, hunted around a little bit, and then landed a job at Pfizer. So I was,
a little pharma company.
Exactly. At the time, they were a device company as well. They had about a $2 billion device business back then. So Halmedica, orthopedics, Schneider, interventional cardiology, et cetera, et cetera. They had several divisions in devices, and I thought, no better place to go to Pfizer, which had both drugs and devices as a place to innovate and create. And so I was really excited to go there. It wasn't until I walked in the door that I learned that the device division never talks to the pharma division. They're like, I want to do this. Like, yeah, that's not going to happen. But anyway, that's why I went there.
Okay. And how long did you stay at Pfizer?
I was there for, I think it was a good solid at least 7 years. They did support putting me through business school. So I went to Columbia Business School executive program. They helped me do that. And really, actually, the experience that I had with Pfizer gave me an opportunity that has actually transformed my entire career. And that was, the guy that hired me was a guy named Hank McKinnell. And at the time, he was the CFO of the business. He's the one that pulled my resume out of a stack.
Okay.
And he was in charge of strategic planning at the time. And then he later became the CEO of Pfizer. But while he was the CFO, he brought me in, gave me this job in business development and technology development on the medical device side. But he literally a week into me being there, he calls me back to his office and said, I got a special project for you if you have time. And he asked me he said, we buy all these really creative, innovative, and rapidly growing businesses. And yet after we acquire them, they suddenly stop innovating successfully, and their growth rates slow and their innovation slows, and I want you to figure out why. And if you have time. And I was like, oh yeah, I'm doing this.
Yes.
So it was a great opportunity because I went and I interviewed all the founders of those companies and their management teams,
right?
The ones that were the before acquisition group, and then I interviewed the presidents and then the teams after acquisition, and just asked them a lot of questions about, how do you find your ideas and where do you go? And what I realized, it was really interesting. I realized that, when they're in the mode of being a sort of like about to be a startup, they're really trying to solve a problem. And then they're just bringing whatever technology makes sense to bring to that problem. But after they're acquired, and that's when they've already been successful and they made a balloon catheter to treat, coronary artery disease or something like that, they become a balloon company. And now they go, well, where else can we use a balloon? Which is a very different proposition than trying to solve a problem. Because when you have a balloon, when you have a hammer, everything looks like a nail, basically. And so that difference, I basically said, I think this is the big difference, is that they suddenly get pigeonholed into this technology. And at the time, the business school think was economies of scale, you find other ways to leverage your manufacturing base, et cetera. And I think that led people down this unfortunate path of where they would basically try to find new products for pretty much what they're already making, rather than saying, you're my customer, what else do you need? And it doesn't matter if I make that today, how can I make that? Like, go do it. And that as a natural course leads to very incremental innovation. So that's why the big companies, for the most part, do incremental innovation, but they don't really do breakthrough innovation that much. And so identifying that difference, I came back to Hank and I said, this is the difference. And he says, well, how can we do breakthrough here? And I said, well, I think the way we would do it is basically take a team, tell them, focus on the problem, let's go and get the problem, identified, and then don't limit them to the existing technologies and solutions that we have. Let them explore which is the best fit. And so we designed a program inside of Pfizer to do that. And that framework, which I did with Pfizer when we created a number of technologies there, and spun them into the divisions. But then after was the methodology that we used for my incubator, ExploraMed, and I still use it today. And then this is also what I teach at Stanford. So that thread, that process that we sort of came up with at Pfizer turned out to be my whole career.
Yes.
Like that moment.
So you stayed there for 7 years.
Yeah.
And then did you come to the West Coast and start ExploraMed?
Yes. First stint, I hooked up with New Enterprise Associates at that time, back in 1995. They, John Nera, and was the general partner, wrote a small check to invest in ExploraMed on this idea that this, crazy young guy with who had this process was going to create deal flow for them. And basically I started on the East Coast, but ultimately brought it all to the West because that's where I felt like innovation was really happening, the Silicon Valley area.
Yep.
And moved out in 1996, and that's the beginning of ExploraMed and all the companies that we've produced since.
So the way you approach it is you identify a problem.
Exactly.
And you put the best minds and horsepower to solve the problem.
Exactly.
Okay. And I know you've solved a lot of problems.
Yes.
So let's go back to the beginning.
And you've had a chance to
yes,
see
I
this
have.
firsthand.
That's going to come out later.
All right.
But was the first problem hearts and vessels and stents?
It was. Yeah, it was. I mean,
my research says that it was.
Yes, it was. Actually, the very, very first one was a urological problem, which was, and that company was bought so quickly, no one ever knew about it. That technology was called Endomatrix. That was actually the very first company that ExploraMed created, and that was for incontinence. And it was an alternative bulking technology to bring the urethra more into apposition around the area of the sphincter so that the sphincter contraction could be more effective. And there were other bulking agents at that time, Contagen, as which is also used for aesthetics, I'm sure, but was being used. But the problem with that is you squirt it in, and then as soon as you take the needle out, it squirts right out. And of course, it's a bovine collagen, which can, potentially trigger immune responses, and then also it doesn't last that long. It gets degraded and all this kind of stuff. So this was essentially utilizing a suture or a thread and using it through a needle, but folding it as a bulking, like sort of like what's inside of a golf ball, like a multi-folded strand. And that would serve the bulking agent, and that was bought by C.R. Bard. So that was our very first one. The second one was our cardiovascular one, which was much more challenging. And
what did you do? What was the problem? Stenosis of coronary vessels?
Basically,
you said, how do we keep them open? Or was this the first stent?
So no. So at the time when we came up with this, the first stent had been introduced, which was the Palma-Schatz stent. It was a very, very rigid stent, and it could only really be applied to very proximal vessels and really only straight vessels. And as you probably know, vessels are very tortuous. So it seemed that the stent, saying this sounds ridiculous now, knowing how technology has evolved, but at the time, that being the only stent, that seemed like it was going to be limited. Okay, and so still, coronary bypass and all of those traditional techniques were still all the rage, and people were talking about, well, how do we do coronary bypass minimally invasively? So companies like Heartport and cardiovascular systems or cardiothoracic systems were little companies that were trying to do like coronary bypass, but we're using ports, like laparoscopic surgery, but using ports.
Yeah. Yep.
And I sort of looked at that and said, I wonder if there's a way to bypass coronary vessels completely percutaneously using catheter techniques, where we could like bypass the vessel, but everyone's down here at the groin with little catheters that were threading back and forth, rather than cracking the chest, rather than stopping the heart, rather than all those things. That was sort of the spec was, wouldn't it be great if we could bypass vessels totally percutaneously, right? And that was the vision for transvascular. And so we developed really from scratch, an array of tools. Like we had to make connectors to connect vessels. We had to make devices that would navigate in and out of blood vessels. We had to design from scratch devices that were meant to reroute flow. Because the basic idea was that if you look at the surface of the heart, if you were to put a model of the heart on the table right now, and you look at the surface, what you'd see is this beautiful left main coronary artery sitting there right across the anterior surface of the heart, and then right next to it, this nice big blue vein, just there, right next to it.
Right.
And so the idea was, can we, for areas where you couldn't get to with a stent, can we sort of like come upstream, pop over to the vein, connect those, go down, come back, connect the distal vein, and basically just use that venous segment on the surface of the heart to be the bypass.
Right.
Like the bypass material's right there. That was the idea. And so we had to develop all the apparatus, and we did it in animals, and it was a little challenging. It was a little challenging. But ultimately what happened was with that company is that the stents evolved much quicker than I anticipated. Mm-hmm. So by the time we were really ready to do humans, you looked over and you said, well, why would you do this complicated thing if you could just get this nice little thin flexible stent down there? Well, yeah, right. That wasn't the way it was when we started the company. It was this big rigid Palmachat stent. But by the time we had gone through all the animal studies and all the development, the basic idea of bypassing proximal lesions, but actually bypassing them, sort of no longer made sense. So then we were stuck with this idea of, well, what do we do now? And we redirected the company towards using the core tools for saving limbs, essentially. Right. And that is where the technology is used today. So the
jump grafts or the venous interposition graft.
Yes.
But let's go back before you tell me where it's at. Yeah. So there you are, and you're doing basically a kind of a version of a cabbage or a staphylos or even an IMA. You're basically doing a vein graft, jumping over the clot.
Graft.
But in order to get to the point where you were doing the stent, you had to get rid of the clot.
No, we left the lesion in, just like you do in a bypass. You don't try to clear out that lesion.
Okay.
We would actually bypass around it.
With the stent even?
No,
with your vein you did.
Our stent went connected artery to vein, and then the other stent connected vein back to artery. So it was like you said, it was a jump graft.
Right.
Leaving the big lesion in between untouched.
Alone. Okay.
Yeah. And
then did that change? At some point, didn't you develop a stent, though, that went straight intra-arterial and didn't touch the vein? The stents that we developed could be used for regular stenting. Okay.
But they were specifically designed to be able to traverse this artery vein gap. But where the technology went ultimately was to allow for, where it's used today, it's that technology is owned by Philips, which had acquired Volcano, and Volcano acquired the Medtronic technology, and Medtronic had bought Transvascular. So it's like, but it's still available today, and where people use it is when they're trying to wire a lesion in the leg, and it's a very diffuse, calcific, difficult lesion in, let's say, the superior saphenous, the femoral vein. And they get the wire down through this vessel, but then they're on the other side, and it's not in the vessel. It's wound up being jammed into the subintima in that wall.
Yeah.
They use our technology to get in there, look around, see where the actual lumen is, and then pop into that lumen. So it allows for traversing back into the vessel. And then they put a stent in, and they squash the lesion aside, and then you basically can save a limb that way. So that's how it's sort of used for that purpose these days.
Okay.
Yeah.
So peripheral vascular stuff.
Yeah, peripheral vascular, pretty much.
Okay. Now, I know there's been a bunch of other problems you solved, so let's keep moving.
Okay.
When did you get to was it a prostate, or what was the next one?
The next one, which was probably, the beginning of sort of me figuring it out. Those two first companies were very challenging, and I learned a lot. I actually have learned a lot in every single company, honestly. But the next one was ENT project.
Was that the sinus one?
Yep. Treating chronic sinusitis. This is a company called Acclarent. And there we, again, need finding, saw that, the drugs don't really work that well for chronic sinusitis. And when you finally wind up in the surgeon's office, the minimally invasive, quote unquote, procedure that they do is FES, where functional endoscopic sinus surgery, where they take these large, rigid, straight tools and go into your nose and essentially rip out and cut bone and tissue to try and find their way to the sinuses, which are down these tortuous pathways, and just to open up the opening that drains to allow it to drain. And it's very bloody, very painful. it actually can cause a lot of scarring, which produces a disease worse than the original because you get scarring now it's closed like a door is shut. And so we saw all that. We said there's got to be a better way. And, sort of the insight there was to understand these tortuous pathways and say, maybe we can approach this just like we do in the cardiovascular system with some little catheter that can navigate to the place that needs to be opened and then just open that, maybe with a little balloon, just the part that needs to be opened so it can drain and not have to cut all of this bones and tissue. And that was balloon sinuplasty. That was a Clarent. And that was a great success. That was the first time that everything sort of all came together. We certainly had our struggles along the way, but clinically it worked. It was great for patients. It was
minimally invasive.
Minimally invasive. It was actually less expensive for the healthcare system because you could do it in the office. And you could really treat. And I've actually had the procedure myself, so it actually helped me too. It was inspired by my own problems with chronic sinusitis.
Interesting.
Yeah.
Interesting. Okay. And thereafter,
then the prostate
one.
Then the prostate one. So the situation there was lots of drugs for benign prostatic hypertrophy, which is the condition that affects majority. It's the most common condition for men over the age of 50. It's a benign enlargement of the prostate gland that makes it more difficult to urinate. So basically, you are going to the bathroom a lot. You can't finish a golf game. You wake up in the middle of the night. It disrupts your sleep. It disrupts your life. It's a quality of life disease. But ultimately, it actually becomes worse than that. If it gets very severe, it can result in bladder weakness and injury so that your bladder becomes damaged, and then you have a real problem and you can't actually urinate without a catheter, and that's a big problem. So you do want to address it. It isn't just a quality of life problem, because if it's allowed to persist, you get this much bigger physiologic problem and even, infections and stuff. So the way it was treated historically was drugs, which are not that great. They aren't that effective, and they have lots of side effects like lightheadedness and, all sorts of things like that. Mm-hmm. And then the other alternative is to get what's called a TURP, a transurethral resection, where they go in with a tool and carve out your prostate from the inside, which is very bloody and very painful, and also can produce impotence and incontinence, which also isn't good. So that's the situation. And then a lot of people had tried to do minimally invasive things. They tried microwaves, they tried all these things, and those really never took on, and everyone believed that there was really no minimally invasive solution for prostate. I mean, I'd say at the time that we were going at this, people were like, why are you even wasting your time? They've tried microwave, they've tried all the ultrasound, everybody's tried everything. And why go after this? It's, everyone's failed. But this gets to why this methodology of approaching problems is different.
Right.
Because we don't just look at the physiological objective. We look at the whole patient. We look at the doctor, right? Mm-hmm. Like as you and I have worked on project, that when we're approaching this, we aren't just thinking, how do you fix that clinical issue? We're thinking about, what does the patient really want to experience, right? What is the experience of the doctor? And when you look at it that way, you realize, hey, microwaves actually do work. But when they put the microwave in there, blast the prostate with all this energy and create all this inflammation, it makes the patient worse for 3 weeks, which means that they're calling their doctor saying, this is not good. I've got to wear this catheter for 3 weeks. Are you kidding me? And then the doctor's not happy. And by the way, the doctor didn't have to even engage in the procedure. They put the catheter in, push the button, and say, I'll be back in the hallway. You just have to be cooked for a while. I mean, it was just like they weren't engaged. So you look at that whole scenario. Now, follow these patients out 6 months. Looks great. Their prostate's smaller. Their flow is better. But are they telling their friends, you should go get this? Absolutely not. No. And are the doctors saying, hey, we should do this thing? No way. So that's why taking all the stakeholders into account and creating what we call a needs specification up front and being really thoughtful about, there has to be certain parameters for the payers, certain parameters for the doctor, certain parameters for the patient, but not just what's the flow rate. It's about what's the experience, right? And so if I were to say what we tried to do is we said, how can we do a procedure where people can jump off the table and pee, and they don't have to take any drugs, and they're not going to get a catheter, and they're going to be good for years, many, many years. Maybe it would need to be repeated 5 years later. Okay, but can we get them like 5 years of not having to deal with their prostate and back to the quality of life, sleeping through the night, playing a whole golf game without going to the bathroom? Can we do that? And then for the doctor, can we give them something where they're engaged and they are involved and they have an opportunity to like sculpt the procedure for that patient and feel like there's a reason why I went to medical school. I can do something unique.
Problem.
Yes, I can solve the problem in a unique way for that patient, not just push a button and walk out of the room. And then can we do it in a cost-effective way so that we actually save money, bring people out of the OR, and give them better. So overall, with all those stakeholders, right? And that's what NeoTract is. It's a way basically the device basically allows a doctor in an office setting with very local anesthesia to go in, push the prostate aside, open up the urethra, and then tack it in place. And then you do the other side and you tack that in place. And if it's a big prostate, you get maybe a few more tacks than that. The tacks heal over. And so you get this durable opening within the urethra that allows for flow, and patients can jump off the table and pee, and they can go home, and they don't have to take any drugs. And for the most part, it's for the vast majority of people, have a really good experience with it.
So it's another tube.
Yes.
That is opened.
Yes.
And kept open.
Yes.
You guys are starting to see a theme here. There's a theme here. We got
There's a lot of tubes in the body.
The tubes drain the sinus. Now we got the prostate. Right. Trust me, there's more tubes to come.
Now, we're into tubes.
Did you keep the same engineers with you as you went company after company? I mean, a few of them, I had the good fortune of getting to know some of them. But you're not a one-trick pony.
No.
You did one and then another and another. And we're just starting down this road, guys.
Right.
But did you tend to keep the same engineers going forward?
Not all, but some. And I'd say they recycle back in to the businesses. Because I think the reason for that is we try to create a culture that's fair and that people are recognized and rewarded and appreciated. And they get a chance to accomplish something in their careers that matters to them.
Yeah, it's exciting. Solve problems.
When you do that, it's like, why not join up again? So there are many of my colleagues who are still in some of these businesses that, when they start to think about what's next, they give me a call and say, well, what else we got,
Yeah.
And I've worked with multiple times, and then some find their careers and they're happy and they stay where they're in those businesses, and that's okay too.
Yeah, that makes sense. Okay, so now we're going to leave the prostate.
Yeah.
Throw another one at me.
Yeah.
I know of a few. There's something having to do with the vagina, I know.
There is. We have one of those. We could jump to that one. I could talk about a failure if that would be helpful.
Yeah, at some point I was going to get to the failure.
Yeah.
There's only been one that I'm aware of, and it's not truly a failure.
Well,
in my mind. It may raise its head again at one point.
That's true.
Give me another one before the failure.
Before the failure. I'd say the next one that is, I think, going to be a big success. And in fact, just today, I was on a call with the CEO, and we have won our pivotal trial, which after literally 10 years of work is a huge accomplishment. And this is a company called MoxieMed, and it is a technology for early stage osteoarthritis.
Okay.
And so osteoarthritis, which is the calcific, and degradation of the inner joint area, that kind of interdigitates. There's a number of places in the body where we have these. Basically every joint.
Joints, bone to bone.
It becomes bone to bone after it degrades. And then lots of pain and lots of, like you don't want to move it because it hurts. And imagine, when it happens in the knees or the hips, it can be debilitating and really accelerate a very poor quality of life and death ultimately, because you don't want to move. And so this also, that disease is also highly correlated with addiction to opioids, and because you're in you're looking for some relief, and so then people get hooked, and so it's a problem for the nation is earlier stage arthritis, and especially in younger people. So younger people being like 35 to 50, younger than me, but when it happens in younger and when you're younger, the docs will be like, well, I don't want to put a new knee in you because they last about 10 years. Mm-hmm. And then like if you're 35 and I put one in now, you'll be back at 45, you'll be back at 55. And your risk of death goes up every time you go for a revision. So they want to put that off. But what do they have to offer you? And literally, it's pain meds. It's don't work as much. Like you could get a brace that you could wear, but that's a pain in the ass. So there really is, and they're trying things like injectables, and none of those really work that well. And so we looked at it and said, okay, here's a need, right? Mm-hmm. You got this situation where again, drugs and stuff not working well. Surgery, way invasive, not appropriate. What else can you offer these people? And can we do it in a way that preserves their joint and gives them, isn't as invasive? And the idea that we happened on was this idea of an external, sort of like a shock absorber that sits outside of the knee, but underneath the skin.
Okay.
It's implanted, so let's say on the femur and tibia, mm-hmm. and it creates a counterforce mm-hmm. right in the area where the would they be touching? The osteoarthritis is, uh-huh. sort of pushes the bones away. And by doing that, the effect is as if you lost, like 100 pounds.
Okay.
And when you take the pressure off, the bones can more readily heal and they hurt less. So you feel comfortable running and walking and doing all your exercise because there's a lot less force there, and the disease itself doesn't progress as much. Okay. So the thesis was, if we put these things in, can we reduce pain, can we improve function, and can we get long-term durability and prevent the need for, and prevent the progression towards a total knee? And that was what we proposed. And so we've been working on this thing for quite some time, and it's been difficult because, part of the reason is that as soon as you put these things in for patients who were active and, first thing they do is they go out on their jet ski and they give it a ride,
yeah.
and
they stress it out.
They stress it out. And we've had over the history of the development, too many of those things that, didn't live up to all the things that people want to do with it, right? So we had to go back, fix it, make it more robust. So over the time, it's taken some iteration to get it right. But finally, we are here with a successful trial. And so this is this will, then navigate through the FDA process, and then hopefully we'll get a straightforward approval and we'll be able to bring it to patients. But this is going to be a revolutionary technology for early stage arthritis, a mechanical solution that will reduce pain and improve function and be a great alternative to total knee replacement or some of these other therapies. And it's going to allow you to have your knee without a replacement and maybe never have to have a replacement depending on how the long-term data stacks up. But this is a really exciting moment actually today.
Will Ortho be putting it in, Orthopods?
Yeah, orthopods and sports medicine.
And it's a kind of a distractor. It distracts
exactly.
the bones, and somewhat of it sounds like on a car.
There's like a springiness. Yeah. There's a spring in there that adds force to distract the bones.
Is it attached to that femur and fibula? So yes. It's attached to the bone.
It's attached to both sides.
Is the patient asleep or awake for the procedure, or can they do spinal or epidural?
We have done it in where the patients are under. It just makes it easier to manipulate the joint and everything. You have to create an incision, and I imagine it could be done. It may, in fact, have been done with a spinal already, but I'm not sure. I think we've done it under general. Okay. But still, it's just it's an incision. Put the thing down.
It's a lot different than replacing your knee joint.
Yes, it is.
Where
it's a lot better.
Cut everything.
Yeah, and you get to keep your knee. Your knee is still your knee. And if any time in the future you needed a total knee, you can just take this thing right out and put a total knee. We specifically designed it to leave all of the surfaces that are required to put a total knee in available. So you can revise to a total knee in the future, but very few patients have in the trial. And so it's really been a great success so far.
Well, congratulations.
Thank you.
Now, before we get to the failure,
thank you.
What about this vagina thing?
Yeah. So I always go in directions where everyone thinks, you can't do something. It's a sickness. I don't know why.
No, you're contrarian. You're trying to solve problems that haven't been solved.
I'm not a follower.
In ways that no one's ever thought.
Exactly.
You're not a follower.
I'm not a follower. I like to blaze new ground, and I like to take on hard challenges. And this was one that was interesting that came across my radar, which was, look, we have Viagra for men, and it's all over the television and everywhere.
Speaking of Pfizer.
Yeah, speaking of Pfizer. But what do we have for women? And basically nothing. And so I got exposed to this need at a urology conference where I met some people that were trying to do some innovations in the space, and they were just saying, like, unfortunately, there haven't been a lot of credible efforts here. And what's happened is a lot of the things have found up being sex toys or things like that. But no one's actually brought any real science, and nobody of any, I shouldn't say nobody. It's been difficult there haven't been very few people with medical credibility that have actually, stepped forward. And, but there was evolving to be. And so there's a whole specialty on sexual medicine, and these folks are champions for this need. But on the corporate side, I think so there were definitely champions on the doctor side, but on the corporate side, there was a squeamishness. VCs are primarily male. We don't want to go here. Of course they can back Viagra, but when it comes to something for women, it's like, I'm not so sure. And then they're afraid of it being porn or something like that. And then, and then on the corporate side, same thing. There's a real insecurity over women's sexual health, whereas there seems to be broad acceptance of men's sexual health, but on the women's side, it was different. And I just thought, this is a social challenge, and it's a technology and medical challenge, and so we, working with a number of great, physicians, Dr. Leah Milheiser, Irving Goldstein down here in Southern California, and really top thought leaders across the country came to understand what the physiology is, and then developed a device that we believed would produce a Viagra-like effect for women. And we were able to get it venture funded. I was, of course, affiliated with one of the VCs that led the way. And we took this on not only as a device for women, but also as a social change opportunity. And that was a hard project too.
And did this go through FDA approval?
It didn't have to.
Okay. So
because our claims,
was it 510K?
No, we didn't. So we did not need, because of the claims that we wanted to make, which was essentially an arousal claim, those are not regulated.
Okay.
So we were able to introduce it as a sort of an arousal device for women, and But the interesting problem, the reason why the company struggled, was not because of the technology didn't work or anything. We did do clinical studies. It was very effective. The idea of it was you use this for a couple minutes, and that promotes these feelings of arousal, which then have both a stimulatory effect, a blood flow effect, and then, of course, even psychological effect of promoting an interest, which women, you say, well, why would we want to promote this? Well, who is this for men? No, women, some there are some women who wish that they have this feeling desire but don't, and don't know how to get it. And actually this device, which, basically promoted blood flow, essentially provokes sort of a feeling of interest. It just does. So the problem was that Google and Facebook wouldn't allow us to be promoted on their platforms.
Because it had to do with sex.
Yep. They said, oh, go over to the porn side of the business, but you can't promote on any legitimate platform. We're like, whoa, wait a second. No. We're separating ourselves from that. Look at our advisory board,
Yeah.
You've met some of these folks.
Yes.
I mean, this is like the world-class advisors in the space. Like, we have clinical data. We are not going to be over here on the porn side. We want to destigmatize it and make it like Viagra for men. And no, we couldn't. I mean, so they are the platform online. You cannot advertise anything online without access to Google and Facebook's platform. I mean, how do you get any word out? How do you communicate with people? You can't. So we were basically censored. And we had a campaign called Legalize V. That was not my idea. That was Karen Long's idea. Of course, Karen well, and Dr. Milheiser's idea. And they basically, they basically picketed it out in front of these saying, legalize V. But we did get a little bit of, movement, but it was too little too late. And at that point, I think we just ran out of gas, and we couldn't. It was hard to convince people that there was a real opportunity there. So we did wind up selling the business. It wasn't a complete failure. We sold it to a business that was in the business of sexual health, had a bunch of other drugs, and it sort of fit with their portfolio. But it wasn't what we dreamed.
Is it being used today?
I think so. Every now and then we do get a call for some of the refills. Like I would say, we redirect them to but it's not it's not the big Generally, we try to take on big opportunities that are going to be like $1 billion, millions of patients type thing. That's definitely not that.
And what's it go under? What's the name now in this new company?
The company that bought it was A2, AYTU, which is sort of a small company in Colorado that has a number of testosterone and a couple of other things like that.
And the device is called?
The device is called Newell's. Newell was the name of the company. The device was called Fiera. Fiera, yeah.
Okay.
So there are
maybe we're relaunching it here on the Technology of Beauty.
It could be.
Maybe a spin-off, the Technology of Sexual Awareness and Arousal.
Right. Exactly.
Okay.
There we go.
Now, problem after problem. Now, tell us about the one that you went after and you call a failure.
Oh, sure. That was targeting obesity. That was definitely
what he said was targeting obesity. Now listen to this.
Yes. So at the time, we were just going back at that time. There were 30 different companies that were thinking of ways of treating obesity. A lot of implants. Lap band was the target. Lap band was really taken off, and surgery was really metabolically successful, but very difficult for patients to deal with. And so we just saw, again, this situation, big and bad invasive surgery, some minimally invasive things that are working, but maybe they could be better. And the primary thing we were angling in on is this: lap bands are so sensitive, they can erode so easily, and they have to be adjusted all the time, and it's a big deal. And lap band, by the way, is a band that goes around the stomach that basically compresses your ability to eat. So it's a restriction technology, and it was finicky. It was successful but very finicky. And so we thought, can we make something better? And so what we developed was a balloon that was the size of a stomach that would sit alongside the stomach and expand and fill the space that the stomach would normally expand into. So the feeling of it would be that your stomach that you were full.
Sure.
So when you feel full, you don't feel like eating. And of course, mechanically, you didn't have a lot of space in your stomach left because all that space under here was being filled by sort of an eggplant-shaped balloon. And also, the nice thing about a big eggplant-shaped balloon is it's a big, broad, soft silicone thing. There's no points of, no high points of force, erosion. So you really didn't see any erosions and really addressed the erosion issue. And of course, it was also very adjustable because it's so big, you could take out, you're not like dealing with a difference of a millimeter like you were at the lap band. It's this big, broad structure. It can be very forgiving to small differences. And so it was more physiologic, potentially.
Was it full of water or saline or air?
It was full of saline.
Saline,
yeah,
okay.
Saline. It had to be full of saline because air would be like this, like a water balloon under, like if you went on.
And how would you access it? Through a port?
Yes, through a port.
Okay.
Yeah, through a port that we put on the.
And how would it get intra-abdominal?
We had a
laparoscopic
insertion. The whole device would get the thing in there, and then we would actually. There was a way to attach it to the anterior abdominal wall. Okay. And that fixated it in place. And then you could adjust it.
Close it, leave a port there,
just
fill it up, just like we would with tissue expanders for the breast.
Exactly.
Okay.
It's just like a tissue expander. Exactly like that.
Yeah, sounds like a tissue expander.
Yeah.
Okay, and?
Well, that company did fail. And I'll tell you the moment that I realized that I felt we had a failure on our hands. Because we were doing the clinical trial and we probably enrolled about 200 patients. And it was the weirdest thing. We had some patients that were total rock stars. Like they lost all their weight. They looked amazing. They were happy. They were the absolute success stories, right? And then you had another group of patients that didn't lose any weight at all. Not a little. We adjust their implants up and adjust their implants more and they were just not losing any weight. And of course, on average, when you average those two bifurcated groups, it's sort of a so-so good result. It was basically equivalent to a lap band. Okay. And we always commit ourselves like if we're only going to be as good as the prevailing thing, we're not going to do this. Like right. I don't want a Me Too. I want a better. It's got to be better. And if it's better, then we're going to do it. If it's not better, then we're just not going to. It's not worth it. So it was not that much better, and we just couldn't figure out if we could just be these rock star people, it would be blissfully, amazingly better. But why were half the patients in this not changing group? And I was surfing online and found a YouTube from one of our patients. Who was talking about the implant. Now, they were in the middle of a clinical trial, and they're not allowed to do this. They're supposed to actually keep confidentiality and so on. But there she is. She's talking about, the implant on the YouTube. And it goes like this. She's like, I'm so very still clearly overweight woman. I'm very thankful to the Vibrant implant. So thankful. So, I used to just sit down and eat a whole pie, for just like over lunch. And now it takes me 4 hours. Yep. So, bottom line is the pie's going in. Yeah. The pie's going in. It doesn't.
So their caloric consumption was equal. It just took them longer to do it.
Exactly. So it wasn't, but the failure there is that it's not here. It's here.
Yeah. That's what
it's here. It's here. It's like this desire to eat, you could feel as full as possible, but the desire to eat is not about having an empty stomach and feeling hungry. It's about satisfying some other need that's more psychological, and that we weren't addressing. And that's why, half of our patients did not lose any weight.
But what's clear to me, and I've heard this story before, is there is still a subset of motivated patients.
Yes.
Who could use this technology and successfully drop weight.
Oh yeah, no, it worked. It worked for them. It worked. But
if you could separate those, if you could vet them,
you could figure it out in advance.
Who's going to be a
right. But the thing is, and this, Grant, because you've worked with so many companies, you kind of only get a chance to get it right once.
You're right.
Because the VCs, you know, like, and I'm a VC, you know, and I get it. It's like after you spent all this money, they don't want to hear like, okay, now we've got it. No, like you're done, you know. And like, could we have? I guess if I thought there was a logical way to figure out who's who, then I might have said, give us this chance. Because I've done that before. I've gone back and said, no, I believe, like Neotract, the urology one, we had a lot of challenges. And I went back and I said, no, believe me. And my mentor and board member at the time, John Nera, you know, went back to him and he was like, you want me to write another check for this? Because we were having a lot of challenge with the FDA at the time. And I said, John, I really believe in this thing. I mean, give us the chance. And he was like, okay, I'm backing you. You believe in it? In this case, I felt the reason why we let it go was I just felt like I knew I wasn't really addressing the issue. Like Noom is more successful than Noom is the right solution to this problem. It's here. It isn't about trying to turn the stomach into the tiny little pencil tube, you know? And so that's why yes, you're right. We could have gone back and tried to do a better job and get there eventually. But for me, you know, what gets me out of bed in the morning is doing something that I know really is the right solution rather than just, you know, making something be okay. I want to do great stuff. I don't want to do so good stuff.
Okay. Now, we've gone through a number of problems that you've solved and you've worked on. You are a doctor by training.
Yes.
Not a single one of these problems falls into pure aesthetics.
Right.
And the two problems that continue to affect us in aesthetics, there are a number, but one is stretch marks, and the other pressing one affects pretty much every woman on the planet Earth, and that is cellulite.
Right. Yeah.
And you and I had worked together on AIS before I got the call from you.
Yeah.
And had the wonderful opportunity to start working with you and your engineers.
Thanks.
And the various cadavers and the labs and all the rest. What a wonderful, wonderful adventure it's been, and I've enjoyed every morsel of it.
You're amazing.
But
you're a great partner.
you identified this problem.
Yeah.
That affects 90% of women that are post-pubescent, and that's cellulite.
Right.
And you said, okay, we're going to go after that.
Right.
And so, of course, the first thing I see is a balloon. You see the theme here?
That was the first idea.
Trust me, it's not a balloon anymore, but I thought that was so funny. We start chasing cellulite with balloons.
We did. We tried it.
And engineers who are used to making little tiny balloons to open up vessels and prostates or whatever.
Exactly.
Okay. And out of that came a new technology that has been FDA approved. Why don't you share that which you'd like to?
Sure.
And
absolutely.
Our CEO is going to be on also.
That's right. So,
but go ahead and tell us a little bit about NC8.
Absolutely. Now called Revell Aesthetics.
Right. But NC8 was what we called it, and that was New Company 8.
Right. We number all the companies so that the name doesn't give away what it is, so we can remain stealth as long as possible.
Yes. Okay.
And in this case, we've remained stealth all the way up until product launch, which will be this year, which is exciting. And I do want to thank you, Grant, for all your guidance and your tremendous input and perseverance with us, because as you pointed out, the first idea didn't work. And we went into the clinic and we tested it and we didn't like the results. And back to what we talked about, we're not just going to push something that doesn't really work that well. We want to go find the thing that kills this thing, that really does it. And it's important. I mean, we spend so much of our lives working on this kind of stuff. It doesn't make any sense to do stuff that's just like so-so. You really, really want to do something that makes a difference. And I committed myself. I've looked at aesthetics many, many times, many other areas, and I'd never done anything in aesthetics before, because I always felt like the results, like if I can't tell the results are better, I can't get into it. For this was a difference maker for me. And our goal was to do something that when you look at it, there's no doubt, even the biggest skeptic, if you see it, you see a big difference. And that's what we were going for. And the idea was, I'd say the opportunity is, there was a historical technology, which is pretty much off the market now, called Selfina, that I know you had a big role in creating. And they got a lot of stuff right, which was that cellulite is where these subcutaneous, fibers, we call them septa, are sort of non-uniformly distributed across the subcutaneous domain between the fascia and the skin, that sort of hold your skin to your body, right? And when they're irregularly distributed, that's fine if they all stretch the same way. But if there's a bundle that has a little bit more girth to it and it's not as stretchy, when gravity acts on the skin, that area doesn't move down with the rest of the skin and basically creates this appearance of a dimple, which is essentially like a puppeteer holding back that part of the skin with a fiber. And so Selfina got it right by saying, hey, no, let's go in and chop those fibers. But what they didn't have a way of doing is being discriminatory about what fibers they were cutting. So they had to cut sort of they had to cut the forest down to get that one or two trees that they really wanted to go for. And that resulted in more bruising and subcutaneous bleeding, and also trauma that really resulted in not a great patient experience for many people. And so the idea of that we want to do is say the fiber idea was the right idea, but how do we do it in a way that is more targeted and just gets the fibers of interest, rather than these techniques and technologies that sort of broadly apply, what have an energy or mechanical disruption across a broader area. And even drugs, can we be more focused? Can we be more focal and just get that structure where it is? And so we, introduced into the clinic. First, we thought we could do it with a balloon, and we thought if we could just put a balloon right nearby, we could blow up the balloon and stretch it enough it would pop. And that failed. But what we learned about that was something that was really also a reason perhaps why Selfina may not have been as effective, is that these fibers are very, very stretchy. I mean, we worked in the lab together on this in cadavers and observed that you can hang on one of these fibers and just pull and pull and pull and pull and stretch and stretch and stretch. And so when you're trying to think about your Thanksgiving dinner and the turkey there, and even though you have the sharpest blade coming at the turkey, from the side, that turkey is just going to move right across the table, right? So even if you're sort of doing this sort of broad cutting technique, you have a chance for those fibers probably to be escaping on either edge of that treatment. So the idea that we came up with, and I'd give credit to the team, there's any of these, by the way, I want to just make sure I give credit. I am not an individual inventor. I always invent with a team, so there's different teams you've met at Bright, John Podmore, we did this together and observed that that basically if you could just grab that fiber and then test if it's the one, right? So you grab it, pull on it, and you see if you can recreate that dimple in the spot where the dimple is, then you've got the fiber of interest. And just zap that one, just cut that one. Then you can minimize your trauma just to that fiber, and you don't have the broad bleeding, you don't have the broad distribution of bruising, et cetera, and you can really be focal about it. And also you give that back to this engagement of physicians. Now physicians can go like a targeted system, that one, and just go for those rather than, sort of a broader distributed approach. And this can really have the potential of being dramatic and instantaneous. And as we both have observed, the power of this is literally these patients stand up, even in the middle of the case, and you can see it's gone. You know, we took the string away. So I really think that this technique, which is a product now, the product's name is going to be called Avali, and we're just introducing it this month. But I really think this is going to transform the treatment for cellulite. And I thank you, Grant, for your excellent leadership and guidance and feedback and encouragement and challenges along the way. But it's been a great partnership, and really, it's been a pleasure. So
it's been a lot of fun. Before we move on to Stanford, I also want to point out something else to the listeners and watchers. So in addition to the ability to identify that one, as he said, called it a thread, fiber, whatever you want to call it. The other thing we learned is that oftentimes there isn't one. There may be one main one, but then it may bifurcate or trifurcate. Right. And when one gets the one, the tendency is then to say, I did it, I got it. But uniquely what this allows, as pointed out by Amanda and some other people who watched every move I made and videotaped it and analyzed it and showed me how to do a better job. And then we looked with endoscopes. There were oftentimes this bifurcation, trifurcation, and so forth that would come up to the skin. We'd go back a second or third or fourth time and hook yet another fiber. So in addition to the precision of getting the one and not sort of undermining the whole buttocks, the other advantage is the isolation of any other collateral fibers, which is an extension of what we learned initially.
Right, exactly.
And that's equally important.
Yep.
So the precision, but also the identification of the other ones, because I think that's what led to the early failures of many of the technologies is physicians such as myself and the people doing the therapy would rejoice mentally, right? They'd say, I got it.
Right.
And there was that feeling of success, and it was. Right. But we didn't think about, well, might there be another one? Yeah. Or a collateral one, like a branch off of a tree?
Exactly.
And it was when Amanda came down a few times and showed me, boy, she's tough.
Yes.
And
Amanda White, one of my fellows from Stanford Biodesign.
Yeah. And I look at it and I'm like, golly, because she broke down when I was successful and I wasn't. Yeah. And it was that rigorous time motion studies and her precise watching these tapes. Yeah. And pointed out to me, and
absolutely,
I know initially as the surgeon, a very successful, accomplished, experienced surgeon, having this your graduate student tell me that I wasn't doing it right. I was like, I'm sorry, but you know what? She was absolutely right. Yep. And when I changed my technique, it worked, and so forth.
Yeah, that's a credit to you, Grant.
It's a credit to Amanda and to the whole team, and the team has been. Yeah.
Caro's an amazing leader. Caro Van Hove, amazing leader, and she's building a fantastic
not even sure
team.
How much I can tell you, but I'll try this and see if this stays in. This included multiple cadavers. Yes. As we had to get it right. Yeah. And included even cadavers coming to my OR and videotaping and so forth. And hopefully that doesn't get cut. Yes. But there has been a lot of fun. It's over years. And then also going out of the country with Craig and so forth. Right. And Craig we just completed 77, I think, people, FDA approval and commercialization. Yeah. And I couldn't be more excited.
Thank you. Me
but
too.
I want to go on because you mentioned Amanda. Would you please share with all of our viewers your position at Stanford, that little college somewhere in the Bay Area?
Exactly.
The department, your position, your chairmanship. So I think that's germane to this whole wonderful story.
Thank you. Thanks so much. Yeah. Well, as this technique of finding needs and solving problems is universal to use to any medical issue, the desire to share that with others and really train innovators to do what we do is really central to me as well, because I'm only going to be able to help so many people, but if we can train others to do the same thing, then we can make a big impact. And so 20 plus years ago, I teamed up with Dr. Paul Yock, and Paul Yock is a famous cardiovascular interventionalist, and we basically started Stanford Biodesign with the goal of training innovators in this methodology. The need finding thing, all the stakeholders go through the sort of identification, need specification, sort of this rigor, And we began with just a small 4-person fellowship, a year-long fellowship, and then a corresponding graduate class at Stanford. I was, came on as an adjunct and have worked for the first 5 or 6 years. I was the fellowship director there. I actually ran that innovation program. And then my startups were just becoming too busy, and I went to more of an advisory and more mentor role with the fellows over all these years. But so now, 20 years later, the program is massive. We have probably touched 12 full-time fellows that are ours, plus global fellows and faculty fellows, and our program, we've written a textbook, and so we're on our second edition. And the teaching is in the biodesign programs have spread across the world, and there's programs in literally almost every country in the world, and many of the states that any place that has a bioengineering program has a program like this. They may use our textbook. And so this idea of this sort of structured innovation approach is really taken off. I mean, it is a simple idea. It's not rocket science, but sometimes simple things really stick,
That's right.
And so we're sitting here now 20 years later with this massive program and international influence. And my co-founder, Paul, is, going to retire. And so the ask was, would I be interested in coming back and running it now? And at first, I've been a general partner at NEA, sort of managing the medical technology and investing practice. But this was an opportunity that I just couldn't say no to. And as I think about sort of the back nine of my career, to be able to take a more direct and active role in shaping the future for biodesign and setting it up for long-term success and sustainability, and that felt like the right thing to do. So now I'm a professor at Stanford, appointed in Medicine Bioengineering, and I'm the director of Stanford Biodesign, and I'm charged with charting the future of what's next.
And that's cool.
Yeah.
And that brings me to my next question.
Yeah.
What is next?
What is next?
You have a crystal ball. I heard you brought it with you. Did you bring it down with you?
I think it's somewhere.
Tell me what 1, 3, 5, 10. What's the future look like?
Yeah. So the future for biodesign will be that, as you know, I'm a device person, but really today the innovations are everywhere. Biotech is huge, so we're going to redimension biodesign to be all life sciences. So it's already happening. There already are biotech companies and pharma companies and digital health companies that our students and fellows have created using our approach, but we're actually going to reinforce that and double down and make all life sciences for biodesign. So we're going to broaden it out. So in the future, we'll have people creating the next mRNA vaccine or whatever it is, or whatever idea it is, that using biotechnologies or whatever it is to solve problems rather than sort of narrow to medical device. So that's number one. Second one is to create a policy program. We're gonna actually create a full-on policy program at Stanford, which will be focused on innovation policy to train policymakers to go into staffing positions in Congress and the White House and understand how technology, especially medical technology, is evolved, so they can better create laws and policies that enhance the ability of medical innovation rather than defeat it. And then the last thread, the new thread at Biodesign, is to really refocus our international and external efforts on really underrepresented and under-resourced parts of the world, and that includes right in our backyard here in the United States, but also internationally, and to use our techniques to help those communities, get the healthcare that they deserve, but have it be the right type of healthcare for their needs and their environment, rather than trying to push, whatever's coming from other places without the same need set. So those are the three things that we're doing for Biodesign. And so that's the future for Biodesign. And
fantastic.
Yeah.
Well, it's been a fabulous
Thank you,
time
Grant.
getting to know
Thanks.
you better, Josh.
Same.
And I'm sure all of you have had a wonderful time getting to know Josh.
Thanks,
I
Grant.
want to thank you so much
Thank
for
you.
coming down, making time in your busy schedule. You've got a million things going. You're one of the
you.
busiest guys I know.
We're pretty busy.
So thanks for coming
Thank
and
you. No,
sharing
I
this
appreciate
time
it.
with
Thanks.
us and the viewers and the listeners. And look
you.
forward to seeing you
Yeah.
as we co-chair various things like AIS and chase some more problems together and solve some more problems.
Absolutely. Thanks, Grant.
Thank
Really
you,
appreciate
Josh.
it.
So there you have it. Thank you all very much for joining us on this episode of The Technology of Beauty, where I have the opportunity to interview the movers and the shakers of the beauty business. And you just heard from one of the biggest movers and shakers of all Biodesign, the chairman, the head guy at NEA, and my partner at NCA to Ravel. See you soon. Stay well. Bye-bye.